A child presents following a fall onto an outstretched hand. I am showing you the radiograph of the wrist. Describe the findings.
Let's see. Yes. The hand and wrist radiograph demonstrates relative shortening of the distal radius with an abnormal ulnar and volar curvature. There is a marked ulnar tilt of the distal radial articular surface, and the distal ulna is dorsally subluxed. The carpal bones have assumed a triangular configuration and are wedged between the radius and ulna, reducing the carpal angle. No acute fracture is identified, and there are no bony exostoses. These findings are consistent with the Madelung deformity.
What is the differential diagnosis for a Madelung deformity, and how do we differentiate the underlying causes?
The differential diagnosis can be remembered by the mnemonic Tildti. This includes Turner syndrome, idiopathic causes, Leri-Weil dyschondrosteosis, diaphyseal aclasis, trauma, and infection. Trauma and infection typically cause a unilateral pseudo-Madelung deformity due to premature asymmetric fusion of the distal radial physis. Diaphyseal aclasis can be recognized by the presence of multiple metaphyseal osteochondromas pointing away from the joints. Leri-Weil dyschondrosteosis is characterized by bilateral deformities, mesomelic dwarfism, and limited wrist or elbow mobility.
Explain the clinical features of Turner syndrome and the typical patient population for idiopathic Madelung deformity.
Turner syndrome is a key genetic association affecting females with a 45XO karyotype. Radiologically, it presents with a Madelung deformity, shortening of the fourth metacarpal, a small carpal angle, and small iliac wings. Systemically, these patients exhibit short stature, a webbed neck, coarctation of the aorta, and a horseshoe kidney. In contrast, the idiopathic form of Madelung deformity is typically discovered in adolescent or young adult females, presenting as a bilateral, asymmetric deformity with localized wrist pain or limited range of motion.
Discuss the developmental pathophysiology that leads to this characteristic wrist appearance.
The deformity arises from premature fusion or growth arrest of the ulnar and volar aspects of the distal radial epiphyseal growth plate, specifically involving the Vickers ligament. Because the radial and dorsal aspects of the physis continue to grow normally, the radius curves abnormally in a volar and ulnar direction. This causes the distal radius to tilt, creating a V-shaped gap into which the proximal carpal row, specifically the lunate, becomes wedged. The distal ulna continues its longitudinal growth unimpeded, leading to its characteristic dorsal subluxation.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these radiographs with prior wrist films to confirm the chronicity and stability of the deformity. I would suggest obtaining radiographs of the contralateral wrist to evaluate for bilateral involvement, which is common in congenital syndromes. I would suggest checking the hand film for shortening of the fourth metacarpal, which would strongly point toward Turner syndrome, and coordinate with the clinical team to recommend chromosomal analysis or endocrinology referral. Finally, I would document the findings and refer the patient to a pediatric orthopedist to monitor for progressive pain or deformity, as surgical osteotomy or epiphysiodesis may be indicated.